أشكر دكتور غادة for her invitation to be with you today. شكرا دكتور سالي للمحاضرة القيمة جدا. My presentation today is about neonatal sepsis and sepsis biomarkers, important points to be considered in Antimicrobial Awareness Week, presented by Heba Azat Hashim, Clinical Pathology Lecturer in Shams University Hospitals, Egypt. My objectives will be concerned about two main elements, neonatal sepsis, the disease burden and diagnosis, special point to be considered, and the second main part of my presentation will be concerned about sepsis biomarkers, different types of sepsis biomarkers, and I will concern about our study here in Ain Shams University hospitals. I will discuss together with you the aim of our study, methodology, results discussion, and finally conclusion and our recommendations. Firstly, why neonatal sepsis? Why we are discussing neonatal sepsis today? Because neonatal sepsis is associated with high mortality and high morbidities among the survivors. This slide demonstrates the different causes of deaths among neonates, and here it is evidence that neonatal sepsis and other infectious condition is present on the top of the list of the causes of neonatal mortality. And according to these new references, neonatal sepsis is account for the second cause of neonatal mortality, with 26% causes of neonatal deaths attributed to the neonatal infection. And this actually percentage is different from one country to another and from one area to another, depending on the infection control policies and the antibiotic stewardship policies adopted in the hospitals. Neonatal sepsis is not only associated with high mortality, but also it is associated with high morbidities among the survivors, including mental retardation, neurodevelopmental disabilities in the form of deafness, blindness, renal impairment, and so on. So good infection control policies and antibiotic stewardship in our hospitals to avoid the spreading of the drug-resistant organisms in our neonatal use is highly recommended. Additionally, the antimicrobial stewardship programs ensuring that patients receiving appropriate antimicrobial regimen, which improve the patient outcome, reducing the adverse effect, including the toxicity and the antibiotic resistance, allowing for optimal resource utilization is highly recommended. Again, the community awareness about the hand hygiene and the infection control policies to avoid the development of neonatal sepsis from the start is also important. This slide for neonatal ICU in our hospital in obstetric and gynecological department. I put this slide to demonstrate to you the high number of devices and the monitoring and the disinfection levels for each of this is very important. The infection control protocols regarding the spacing between the beds and the number of the nursing for each neonate, and all of these items is very important and critical to cut down the number of neonatal sepsis in our hospitals. From clinical point of view, regarding the sepsis progression, sepsis begin by the SIRS, systemic inflammatory response syndrome, and once the patient develop confirmed or suspected infection, he get into the second step, which is sepsis. If he develop end organ damage, so he get into further step, which is severe sepsis, and if the patient develop resistant hypotension, so we get into septic shock and finally death. And this cascade actually can occur very rapidly within the matter of days or within even the matter of hours. And so early diagnosis, follow-up, and the proper treatment, proper management is very important, not only to increase the survival rate of our neonates, but also to improve the prognosis among the survivors and cut down the neurodevelopmental disabilities among them. Second part regarding neonatal sepsis, special point to be considered regarding early accurate diagnosis. It can be achieved by rapid and accurate blood culture results, and the blood culture remain the gold standard for the diagnosis of neonatal sepsis. We have to use good techniques for the blood culture and good methodology for the blood culture, like Bactic system in obstetric and gynecological department and in pediatric department for the diagnosis. Sampling issues should also be addressed. Low quantity of the blood samples in neonatal population is very important point, especially in the very low birth weight neonates. Again, avoiding skin contamination to avoid false positive results by the staph coagulase negative, which is also considerable organism in a patient with neonatal sepsis. A blood volume of at least 1 milliliter is needed to reliably exclude bacteremia. This is according to the reference that I cited here, published in the 2023, at least 1 milliliter. And there is some debate about the volume. At least 1 milliliter is needed to reliably exclude bacteremia, but the recommended is higher than 1 to 3 and up to 5 according to some publications. Point of care verification of the blood culture volume using a scale is feasible to implement it into everyday clinical practice, and the notification of the blood of the positive samples is very important. As soon as possible we get a positive sample, it should be notified because the time is everything in the management of our disease. Good and rapid processing of the samples from the microbiology site and microscopic identification by the well-trained microbiologist and the gram stained smear reading is very important, and selective reporting in the antibiogram is also critical in our disease. Striking a point I wanted to stress about it here is that wet film from the blood culture bottle and from the CSF with the notification of the positive results as soon as possible is also recommended. Another point is a comprehensive interpretation of the laboratory results together, not just the result of the CRP or the CBC indices. We need the comprehensive interpretation from the clinician side to reach to the proper clinical judgment of his patient. Using rapid and accurate sepsis biomarker is also recommended worldwide in the neonatal ICUs to cut down the high use of the antibiotics and its complication, and to decrease the dilemma of the drug resistance. Another point is very important is the implementation of sepsis biomarkers in the routine daily sepsis profile workup, especially in Shams University hospitals, and to transmit the researches and the bench, the sepsis biomarkers from the bench side to the bedside to be helpful to our neonates and our patients. Final point I will concerned about here is the combination between the different sepsis biomarkers. I mean by different sepsis biomarkers to use combination between conventional laboratory parameters like CBC and CRP in combination with new sepsis parameters like CD64, like procalcitonin, like Percepsin for more accurate diagnosis. I bought this slide to demonstrate that wet film from the blood culture bottles, once we receive the bottle, is very important for the diagnosis. And I will never forget one patient that I received the blood culture bottle from him, where we was in Ain Shams University Specialized Hospital. She had signs of neonatal meningitis. Once we did wet film from the blood culture bottle, we see fungal hyphae. We report to the treating clinicians that we have a fungal hyphae in the blood culture bottle. 1 hour from receiving actually the bottle, so the treating clinician began Vivant at the time, and the patient greatly improved. This is one of the models that improving the patient can occur without neurodevelopmental sequelae and without neurodevelopmental disability, just from special points that we can meet, like a wet film from the blood culture and from the CSF once we receive it. This slide demonstrates summary of the current continuous monitoring blood culture system, including the BACT alert, Bactic, and the VersaTrack, and the recommended one for the neonatal population and the pediatric population here, as it is evident in the Bactic system. And what we will do after the positivity? After the positivity, we have to make identification of the microorganism, either by the phenotypic or by the genotypic. The use of the molecular rapid diagnostic techniques with the antibiotic stewardship, according to these references, had an 80% chance of being cost effective rather than making just identification and reporting. So the identification in combinations and in coordination with the antibiotic stewardship is very important for better clinical management and for clinical judgment. The second part of my lecture will be concerned about sepsis biomarkers, and I put this slide to demonstrate that there is a high battery of the sepsis biomarkers studied nowadays, and the point not just to say this biomarker is sensitive and this biomarker is specific. It is a matter of statistical evaluations with statistical equations, including combination of the different of them, to know which is better and which is the best to be routinely adopted, and not only for the diagnosis but also for the prognosis, for monitoring the patient, for the prediction, and for the stratification of the disease. Second question in my presentation is why biomarkers? Why I study biomarkers? Because actually the traditional culture methods that I already mentioned has some limitations and diagnostic obstacles, including the time needed to obtain the results. Like in the blood culture, it may take days for releasing the positive results, low sensitivity of the tests in some circumstances, and impossibility of excluding contamination for some patients. Diagnosis of neonatal sepsis depending on three main items: the clinical diagnosis with sepsis score, secondary the radiological diagnosis, which is very important, especially in patients with pneumonia, and third item, the laboratory diagnosis, which is dependent on two main items, which is the conventional diagnostic methods and the new diagnostic methods. Conventional diagnostic methods including the isolation, hematological studies, and the acute phase reactant, while the new diagnostic methods including the molecular techniques and the sepsis biomarkers. The new trend in the different neonatal ICUs worldwide is the combination between the conventional methods, including the hematological indices, CRP, and the blood culture, in combination with new biomarkers like CD64, persepsin, and procalcitonin for rapid and accurate diagnosis. The challenge of biomarker identification is reflected by the fact that over than 3,000 sepsis biomarkers studied last years, including hematological indices, CRP, procalcitonin, cell surface marker, which is my concern here in this study, and genomics, proteomics, and metabolomics even being used. Metabolomics, including the calcium level, including the albumin, the calcium albumin ratio, including the lactate level, and including some of the metabolics being included in different equations for the diagnosis and for the prognosis of neonatal sepsis, is being discussed and being published last year. Hematological indices is also important for the diagnosis, but actually it is associated with some diagnostic obstacles and disadvantages, including non-specificity. Even the total leukocytic count and the platelet count can be affected by the mode of the delivery, the age of the patient, even the site of the venipuncture. And an additional point is that the neonatal sepsis is a dynamic disease. Dynamic disease passing through different stages. First stage, which is hyperactive stage, and secondary hypoactive stage. So the patient himself, the only one, can go into leukocytosis followed by leukopenia, thrombocytosis followed by the thrombocytopenia, according to the different stages. So the interpretation of these items, hematological indices, should be in caution and in correlation with the patient clinical condition. This hematological scoring system is done to help the clinician in deciding and in the diagnosis of neonatal sepsis, and can also be adopted and implemented in our hospitals. Regarding CRP is the most extensively researched sepsis biomarker worldwide since 1930s, and it has a wide range of variety of diagnostic efficacy and diagnostic performance, but in general, its diagnostic efficacy is medium, not so high, not so bad, and the point is a highly sensitive CRP protein. This is being recommended to be implemented in the different neonatal ICUs and in the cardiology unit. This This ultra-sensitive immunoturbidimetric and uveilometric assay is capable of measuring CRP at a very low concentration, as low as 0.02 milligram per deciliter, even higher than the traditional CRP by more than 20 times. Procalcitonin is being adopted in different neonatal ICUs, but it is not available in our hospital, in Shams University Hospital. It has a higher sensitivity and specificity than CRP to predict sepsis in neonates, and it also helps reduce the duration of antibiotic therapy, but there is some disadvantage and limitation of using the procalcitonin, including the dynamic cutoff range, depending on the clinical condition and the age of the neonates, and its accuracy in neonatal early onset sepsis is still an issue of controversy because its physiological increase over the first 48 hours of life. What about the genomics and the molecular diagnostic techniques? Nowadays, different publications concerned about the molecular diagnosis, including the long non-coding RNA and the S13 RNA. And I will concern here in my presentation about the limitation of the molecular techniques. There is a different limitations of the molecular techniques for the diagnosis of neonatal sepsis, including false positive results, especially that molecular techniques detecting DNA rather than detecting the pathogen. It can be falsely positive or patient who already having a killed pathogen by antibiotic. False negative results if the patient underwent into antibiotic therapy, so he can give negative results. Again, the molecular techniques can give a false negative results in patients who infected with pathogens that are not targeted in the assay. So we have to use pan molecular technique, which is usually financially not available in different healthcare facilities. Proteomics is one of the highly studied part of neonatal sepsis in the last years. Mass spectrometry has become a major analytical tool for studying the array of the proteins in the organism and its arrangement. This can give us an idea about the neonatal sepsis, its diagnosis, and its prognosis. Novel laboratory markers, including also sepsis cell surface markers, including CD64, CD11b, and monocyte CD14, and the different other sepsis biomarkers. I will stress here about the neutrophil CD64 and perception, which is my concern in the studies that was performed in Shams University Hospital. Neutrophil CD64 is a cell surface marker present on the surface of the neutrophil and on the surface of the granulocyte in general. It increased and upgraded in the presence of the pathogen and in the presence of the infection. Perception is another pioneer and another promising biomarker, sepsis biomarkers used in the different neonatal ICUs worldwide. It is a breakdown product of the soluble CD14, which is formed by shedding of the CD14 from the cell membrane into the circulation, and also it is secreted directly from the hepatocytes. Why these biomarkers specifically? I studied in Shams University hospitals because a high number of publications showing promising results regarding both biomarkers. And again, these biomarkers can be available for the routine application in our hospital because their devices is available in our hospital regarding the flow cytometry and the bath technique, with the chemoluminescent assay is also available for measuring the perception. The first research we did in Shams University was regarding the comparison between neutrophil CD64 compared to the highly sensitive CRP, as regarding the diagnosis, as regarding monitoring of patients with neonatal sepsis in the prognosis. It was under the supervision of Professor Amira Mohammed Mukhtar and Professor Shireen Ahmed Al-Masri, Assistant Professor Nuruddin Abdelal, and it shows a promising results of neutrophil CD64 comparable to the other conventional laboratory methods, showing higher sensitivity and specificity and diagnostic performance. And the best combination was achieved by CD64 plus highly sensitive CRP, achieving high sensitivity and specificity. CD64 at the cutoff level 43%. So we recommend to be used as a routine sepsis biomarker in our neonatal ICUs. And since that time, CD64 is used and ordered from the flow cytometry unit to help the diagnosis of patient with neonatal sepsis. The following research was done by my supervisors, Professor Amira Mohammed Mukhtar, Professor Shireen Ahmed Al-Masri, Assistant Professor Rania Abdel Halim, and Assistant Professor Nuruddin Abdel Al, the head of neonatal ICU in Shams University Specialized Hospital. And this study was concerned about comparing the neutrophil CD64 comparable to the Percepsin in terms of diagnostic, prognostic, and monitoring in neonatal sepsis to know which is best and which is better than the other to be routinely applicable. The aim of the study was to evaluate each of them and to compare them comparable to the conventional laboratory method to decide which is best fitting for the routine daily use in our neonatal ICUs. And our aim was to answer the following questions sequentially. The first one, what about the diagnostic performance of each of neutrophil CD64 and Percepsin in neonatal sepsis? The second question, what about the comparison between them? The third question, which panel of biomarkers achieved the best diagnostic performance? And the fourth, what about the monitoring power of each of them to be used to monitor our patient? And finally, what about the prognostic performance of all of them? 235 neonates were enrolled from the 3 neonatal ICUs, from the obstetric and gynecological department, and from the pediatric department. And the patients were classified into control group and sepsis group. And sepsis patients were selected according to the guideline definition of the sepsis, internationally published. Patients were classified into 5 main groups, including healthy controls, including pathological control, group 2. This pathological control was intended to be included in the study to compare the results of these biomarkers comparable to the pathological control. Because actually in the routine daily work, we don't measure the biomarker comparing the patient with neonatal sepsis comparing with the healthy naive patient. We comparing with the pathological and disease patients. So we were intended to include this group in the study, which is pathological control patient with other diseases, but the sepsis was rolled out from them. And three other groups were included according to the severity of the disease: clinically suspected sepsis patient with negative blood culture, and group 4 blood culture proven sepsis, and severe sepsis and septic shock group. Each neonate were subjected for the following blood culture, which is a standard for the diagnosis: CBC with differential, CRP, highly sensitive CRP actually was used, flow cytometric analysis, CD64, and finally Percepsin by the chemiluminescent assay. Bactec system was used for the blood culture results, and the Coulter LH750 was used for CBC with differential, flow cytometric analysis for releasing the result for both the formula CD64% and CD64 MFI, mean fluorescence intensity, and the chemiluminescent assay by using the BUS technology for measuring the Percepsin. Sampling precaution for flow cytometry, we have to use CBC samples. We have to use fresh samples, not more than 24 hours. Samples taken during the holiday or sample taken during the day before the holiday is rejected. And this is some of the obstacles. No clotted samples and not less than 0.5 milliliter of the blood, which is a point in the neonatal populations. This point also regarding the sampling precaution of our test. What about the results? The results showing significant increase in both CD64 and Percepsins in patients with sepsis comparable to the controls. But the higher sensitivity was achieved by the CD64, achieving 94.7%, while the specificity was higher regarding the Percepsin, achieving 95.5%. Regarding the monitoring, CD64 and Percepsin was showing good and promising results in monitoring of our patient in the term of the delta change percentage between the first and the follow-up evaluations. Comparative statistics was done, and I suppose that each of these biomarkers is a horse, and we are in competition, and we need to know which one will win the competition in getting the first, comparable to the conventional laboratory parameters, comparable to the platelet count, to the total leukocytic count, the band, and the absolute lymphocytic count, absolute neutrophil count. The comparison was done comparing the healthy controls versus sepsis and the pathological control versus sepsis, and this showing that CD64%, CD64 MFI, mean fluorescence intensity, and perception, and the highly sensitive CRP actually showing differences and significant differences between both the groups comparable to the sepsis patients. Regarding the diagnostic efficacy, the highest sensitivity was achieved by CD64, followed by perception, followed by highly sensitive CRP. But the best combination showing the highest efficacy in the term of the sensitivity and specificity was achieved by the combination of perception and CD64. But this combination cannot be available in all of the neonatal ICUs, in our hospital neonatal ICUs. So if this is not available to make both the biomarker, so we can use any of these biomarker, perception or CD64 combined with highly sensitive CRP as a second combination with also a good and promising results. This row curve demonstrates that CD64% achieve the highest AUC, followed by perception, followed by the highly sensitive CRP. Multi-regression analysis also was performed, or we did multiple models between the different biomarkers to know which panel of biomarker achieving the highest diagnostic efficacy in general, and the highest diagnostic efficacy was achieved by this model. The third one achieving the F ratio 262, which is very promising, by the combination of CD64% plus perception. If this combination and not available, so we can get into the another one, which is published in our another publications regarding CD64 combined with the highly sensitive CRP, which is also achieving good and promising results. The fourth question in our statistical analysis was about what about the monitoring power of neutrophil CD64 and perception in neonatal sepsis. And for answering this question, we make first evaluation and follow-up evaluation after 5 days from the first one, and we make a delta change percentage between the first and follow-up evaluation divided by the level before. To know the delta changes between each of them, and we divided our patient into two groups: patients who are still continued in sepsis and patients who are getting improved. And the delta change percentage showing that CD64% achieving the highest value, followed by perception, followed by the platelet count, and finally followed by the highly sensitive CRP. The final question in our statistical analysis is what about the prognostic performance? Can any of these biomarkers predict the disease and know the severity? So we comparing patient with severe sepsis, septic shock versus patient with non-severe sepsis, and the promising result was achieved by CD64 MFI, mean fluorescence intensity, CD64% highly sensitive CRP and the platelet, while perception showing a non-significant value in such concerned issue. What about the conclusion? The conclusion of this part is that neutrophil CD64 and perception biomarkers are significantly higher in sepsis patients than the controls, suggesting their potential use for early diagnosis of neonatal sepsis in routine clinical applications. The highest sensitivity achieved by the univariant sepsis marker is recorded by CD64, while the highest specificity documented by the perception. Highly sensitive CRP achieved the remarkable specificity, but actually it is associated with undesirable sensitivity, make it less ideal in early sepsis diagnosis. The best diagnostic efficacy for early sepsis diagnosis can be achieved by the combined of both neutrophil CD64 percentage plus perception. Either neutrophil CD64 or perception can be used individually, while combined measurement of neutrophil CD64 or perception with highly sensitive CRP gives a better diagnostic validity than any of them alone. So if this combination is not available, we can use any of these biomarkers combined with a highly sensitive CRP, which still can give good diagnostic results. Both neutrophil CD64 and perception are valuable markers for monitoring purposes of neonatal septicemia, but actually these results should be combined together with the other sepsis laboratory parameters and in the context with the patient medical clinical condition for best clinical judgment. And finally, neutrophil CD64 carries a promising role over perception in reflecting sepsis severity and in the sepsis prognosis. I put this slide to demonstrate that transmission of the research work from the bench side to the bedside and the availability of such a promising beneficial biomarkers, neutrophil CD64 or perception on the routine basis, besides it with the medical orientation about its interpretation in the context with the patient clinical condition and the different clinical variants is highly recommended to transmit all of these researches that done by the clinical pathology, by the pediatric department from the bench side to the bedside is highly recommended. The home message. This is a slide from one patient that was suffered from neonatal sepsis in his neonatal period. The home message of my presentation is neonatal sepsis is associated with high mortality and morbidity among the survivors. Better infection control measurement and antibiotic stewardship is highly recommended for prevention of the disease from the start. Early accurate diagnosis is very important and critical for better outcome. Considerable improvement can be done in the pre-analytical aspect of the blood culture collection that impact the patient care. Again, there is newer methods developed in the recent year to improve the time to reporting the blood culture isolation identification and the antibiotic susceptibility testing to be used. The successful utilization of rapid identification and antimicrobial susceptibility results required coordination with the antimicrobial stewardship programs. Again, implementation of sepsis biomarkers in routine daily sepsis profile workup is very important. The combination between the different sepsis biomarkers is recommended for better outcome and for better clinical judgment and to limit the use of the antibiotic resistance development in our hospitals. And finally, in spite of CD64 and perception are more fitting for the routine application as a part of the daily sepsis profile evaluation, both are more costly than CRP. We have to admit both are more costly than CRP and represent a financial burden, but actually changing the antibiotic prescribed, catching the false positive results, avoiding performance of unnecessary organism typing and antibiotic screening, in addition to saving the cost of nursing care, bed charges, treatment complication, and antibiotic resistant. This is as a whole will absolutely make the expense of performing of these new biomarkers is therefore more than compensated for the potential savings generated. This is my references. And finally, I finished my presentation. Thank you. Thank you for your attendance and thank you for your listening.